In the beginning, we had a world-changing vision to unite international retina societies, with each of our last two editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last two editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last two editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last two editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last two editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the third edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, We had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together.
Here with you. That's wonderful. With old friends and new friends, and praying that everything gonna finish very soon, and we're gonna have time to get together for dinner, for lectures, for everything around the world. But right now, we are very happy to have all you here. Please, we're gonna start with very good video from Mauricio Azulay from Argentina. Mauricio, please introduce yourself and start your video. Thank you.
Hey, thank you, Jorge, for the invitation. It's an honor for me. I work in Pedro Lagley's Eye Hospital in Buenos Aires. And I brought a case of, should I play the video? Can you see my screen?
Yeah, sure.
I brought a case of a 25-year-old male patient. he presented with a pigmented lesion in the infranasal quadrant of his left eye, had IPEMA and risk factors of malignancy. It's IPEMA and inferior quadrant location and young age. The lesion was in the iris, in contact with the angle, but did not reach the ciliary body, luckily. So we decided to perform an iridocyclectomy. We cut the iris, leaving 1 millimeter of free margin. Then we did a scleral flap, and we tried to cut until clear cornea. And then this is the most dangerous part of the surgery, because you have a big incision and you're working with a bloody tissue as the uvea. Here we cut the uvea and take out the tumor out of the eye. And after that, we close the scleral flap and the conjunctiva. One of the difficulties was the infranasal location. So I sat on the right side temporarily to the patient's head to work in this quadrant. And that's the video. I can show you if you want some pictures of the pre and post-op. This is the pre-op, and this is the post-op 1 week. The patient luckily did well. He maintained his 20/20 vision, had some glare because of the lack of iris in the inferior nasal quadrant, and the lesion turned to be a dysplastic melanocytic cell nevus. That's my case. I don't know if you have any questions.
Very good. Amazing surgery.
Thank you.
I'd like to add some moderators to comment, like Maria, if you want to comment this surgery, please.
Yes, this is a beautiful case. So the patient was phakic. I saw
Yes.
that the patient was phakic. So what type of viscoelastic did you use for this?
I use dispersive viscoelastic. I put some in the anterior chamber, but a little bit of it under the iris to avoid touching the lens while cutting.
Yes, and I did not see you using any cautery. Any diathermy? No?
I did not use diathermy. I thought it wouldn't be enough to cauterize the uvea, to use cautery.
Okay. Beautiful case.
Thank you.
Oh, very good. And Barbara, you want to have some comments?
Barbara says if there is some precaution to limit the cell seeding. Yes, in all time you have to avoid touching the tumor, and it's better to use new clean instruments to close the conjunctiva and the sclera also.
I have seen proposed the use of a cryotherapy locally, even when we inject intravitreal chemotherapy for retinoblastoma, things like that. So we don't have the need in a tumor like this to follow the same procedure, same precautions when we enter and exit with the lesion.
Okay, yes, cryotherapy, it's an option we did not use in this case.
Okay. The differential diagnosis was difficult. You were sure that was malignant and the indication of surgery was the right one?
Clinical, it had signs of malignancy. You don't know until you have the pathology's result, but we discussed with the patient, what about the option of taking only a part of the tumor to do the analysis, but it would imply 2 surgeries. Because and the patient did not want 2 surgeries.
Okay.
I have two comments. One from Arturo. Please, Arturo, go on.
What more you said?
Congratulations for your case, Mauricio.
Thank you, Arturo.
2 questions. I did a couple of cases like you, but sometimes these patients develop a cataract. Why you didn't do a phacoemulsification in the surgery?
The patient was 25-year-old and he had useful accommodation. So luckily, he did not have cataract in the postoperative period, but eventually he will have. And in that time, we are planning to put a Morcher capsular tension ring to cover the iris defect.
And the other thing is that it's very important to do a UVM
Yes.
Before the surgery, just to know the extension of the tumor and if it goes through the angle or not.
Yes, we performed, and it was in contact with the angle, but not in contact with the ciliary body.
I think we have a last question for Anderson. Please, be quick, Anderson. Turn on your microphone.
That's Morning, everybody.
Morning.
For beautiful surgery. My question is, you usually work with the pathology in the OR because I'm afraid of the margin of the tumor.
No, not generally. We do not work with the pathology in the operating room, and the lesion turned to be free of lesion in the margins, so that was okay. It's an exception for us to bring the pathologist in the operating room.
So, what's the margin? Do you think it's the best?
In the iris, you have to keep 0.5 to 1 millimeter of margin, but in the ciliary body, it is 1 to 2 millimeters. You have to leave of free margin.
Thank you.
Thank you.
Very good. Now we're gonna move and have the Olivia from Bolivia. Very nice meeting you. I hope you introduce yourself. It's gonna be great.
Hi, good morning. I feel very honored by the invitation to this webinar. Thank you. Here is a case. A 48-year-old healthy woman presented with a 4-day history of sudden vision loss in her right eye. The visual acuity was counting fingers. Fundus examination showed a dome-shaped red hemorrhage in the macular area with a glistening reflex. The OCT revealed 2 distinct membranes, a single highly reflective band corresponding to the ILM and an overlying membrane consistent with the posterior hyaloid. After a month without visual improvement, she presented with a dense vitreous hemorrhage. V-scan ultrasound confirmed a premacular hemorrhage. Therefore, a 25-gauge sutural sparse plana vitrectomy was performed. After removal of the vitreous hemorrhage, a posterior vitreous detachment was created. We were able to identify the sub-ILM location of the hemorrhage. The ILM was sustained with brilliant blue dye, and hemorrhage was aspirated after peeling the ILM using an asymmetric forceps tip. Fluid aid exchange was performed and the residual foveal deposits could be extracted. At 1 month, her visual acuity improved to 20/25. Fundus examination showed resolution of the hemorrhage, and postoperative OCT revealed the foveal depression preserved.
Congratulations, Olivia. It's beautiful. I love your surgery. And I'd like to address these comments for Tarek. That's our president. Please, Tarek.
Yeah, Olivia, congratulations. A lovely case and an outstanding result from that case. So the etiology of the hemorrhage, maybe I missed that, but what was the presumed cause? Maybe a macroaneurysm or something like that?
The patient medical history was unremarkable, and she denied chronic disease, medical history of trauma, heavily strained coat, or intense sexual activity. So we think it was a submacular hemorrhage secondary to Valsalva.
Valsalva, that's very impressive. Did you do a fluorescein angiogram to see if there were any small macroaneurysmal lesions that maybe
we did after
closed
surgery, and it was everything okay. She was a healthy young woman.
Okay, that's very impressive. Nicely done. I think you waited an appropriate length of time to see if it would clear. It got into the vitreous cavity. With all of those foveal hard exudate deposits, it would have taken quite some time, I think, for her to get a return of her vision. So very nice case.
Very good. Now, I'm going to ask one of the biggest retina specialists in the world, our friend, and that's it's here. It's Praveen Dugel. Please, Praveen, can you comment, because are very important for us?
Well, with that introduction, I'm sure to just disappoint you no matter what I say. So, hello, everybody. It's great to see everybody. It's just there's nothing better than being with friends at a terrible time like this. And Olivia, thank you for the case. That was a wonderful case. I think the main thing with this is two things. One, Tarek already hit, which is to say what caused this, and you've already answered that. The second question really is, what is the right time to intervene? Especially with younger people, when there's a inflammatory cause, the last thing that we want to do is to intervene too late, where you get fibrosis and so forth. And your case showed that yours was the perfect time to intervene. So I think the main thing here, the lesson to be learned, other than what Tarek said, which is to find the cause, is to intervene at the right time before there's macular distortion and fibrosis. And you've also did exactly the right thing, which is to remove the posterior hyoid, so that they will take away that fibrous tissue matrix for further inflammation and for further fibrosis in the end. At the end of the day, we're just trying to preserve the macula and the fovea, and I think you did a wonderful job with that. Thank you for sharing the video.
Thank you, Praveen. And Barbara wants to have some comments too.
Just to know, it was a huge hemorrhage. It was elevated. You could see the hyaloids. Would you try also YAG laser, or would you think it's too dangerous compared to vitrectomy? If you go back, would you attempt to displace the hemorrhage with YAG laser?
Yes, the decision of appropriate treatment option depends on the presentation and the circumstance of each case, the underlying disease, the patient age, durations since the onset, and the size of the hemorrhage are highly relevant factors affecting the decision regarding the type of treatment. Here in our case, she was, after a month, she was with a dense vitreous hemorrhage. So when the hemorrhage is less than 1 disc diameter, it tends to spontaneously resolve in a short period. But by contrast, the spontaneous resolution of large and dense hemorrhage, as we presented in this case, it's very unlikely. So here, pars plana vitrectomy is a treatment of choice for patients presenting late or when hemorrhage fails to resolve following observation or a YAG laser membranotomy.
Okay, so you would not consider YAG laser?
I think so. I think she's not considering YAG laser.
Okay.
Thank you, Olivia. Beautiful case. And just update everybody, you have more than 700 people attending the meeting right now in more than 20 countries. Thank you, everybody from the world, to join us. And now we have a very good friend for Uruguay, That is Juan Bianchi. Please, Juan, introduce yourself and start your video.
Okay, can you hear me now? Can you hear me?
Yes, very good.
Yes.
Okay, perfect. So thank you for the opportunity to share this case with you. Thank you to Retinal World Congress Committee, and thank you to the Pan American Association of Ophthalmology. Okay, well, this is a 43-year-old woman with a optic pit maculopathy history, and a visual acuity was 20/50 in her left eye. She had this macular schisis and its communication with the optic pit. But now the patient comes to me with a decrease, the acute decrease in visual acuity. The visual acuity was 2200, and she had this outer macular hole. So we decided to perform a 25 gauge pars plana vitrectomy, inducing PVD. And then we stain the ILM under air with beryllium blue. I start the peeling with fine flex loop, and then I continue with ILM forceps. At the moment, I was concerned about whether or not I should perform foveal sparring peeling, but I decided to try with a soft and a slow movement involving the fovea. We took special care with the fovea because the possibility of breaking the roof of the macular hole. We didn't have any problem. So after vitrectomy, we perform autologous scleral flap. We use crescent knife to draw a partial thickness of scleral flap, as you can see, with a triangular shape in the inferior nasal quadrant. We put this scleral graft with ILM forceps into the pit with a soft maneuver and under solution. And then we perform a fluid air exchange with a slow aspiration with the soft tip to prevent the movement of the graft. And then we inject a non-expansible concentration of C3F8, and the site of the graft was left free. After 1 month, this is a few days ago, the graft is in position, the OCT confirmed this position and the anatomical recovery of the macula, and the great improvement of the macular schisis, and the partial restoration of the macular hole in the foveal scan. So finally, the visual acuity improved from 2200 to 2060. And here's a comparison between pre and post-hoop. So that is the final of my video. Thank you.
One great case of optic nerve pit, and you perform beautifully with scleral graft. And some people are more conservative, and others are like you, that's do everything. And I address the question for Maria, what to think about this procedure, what you used to do.
Yes, this is a beautiful case, and since I've seen this technique described, I've been waiting to get one to try it because I think it makes sense. But my question to you is, I know that normally when we do these cases with gas, it takes a very long time. They do resolve, but it takes a very long time, and sometimes they can recur, which, we probably don't have enough follow-up with the plug. But this is actually something that really, makes sense anatomically. But my question to you is, there's been some papers about this abnormal tissue being on the edge of the optic pit that helps keep it open. So maybe, condensed vitreous or whatnot. So do you remove anything on the edge of the pit before putting this, or no?
Okay, thank you for the question, Maria. I don't see this tissue in the surgery. So when I do the posterior vitreal detachment and then the ILM peeling, and I didn't see this tissue, but in this case, in particular case, if I put a plug into the pit, maybe this is not a problem with this tissue. I don't know.
Yeah, I also like that you do it in a triangular shape.
Yeah.
I've seen others describe, because it makes it so much easier. It's almost like, like a little, so much easier to place and to keep it there. So very, very nice case. I really like that.
Okay, thank you.
Your case is so beautiful that many people are discussing here. You can see in the chat. But I'd like to hear from Andre Maia. He said that he used some case with amniotic membrane. Please.
Hi, George. Can you hear me?
Very good.
Hello. Okay. I have done a few cases, and I'm using amniotic membrane in these cases like this. One thing also we could be using is ILM. So you do the peeling and put the ILM in the hole. The only concern I have with the ILM is that sometimes the retina is so thin, and I'm afraid of causing a macular hole. But I know it's very rare. Anyway, but I think amniotic membrane is for us in Brazil. It's very easy to get, so that's I think is our primary choice for this kind of case.
And Tarek, you're asking some questions here. Everybody wants to hear you.
Well, the interesting thing about these cases is it's so beautiful to see it work like that. One, it's a wonderful case. There's been controversy for years about the best way to approach these, largely because we don't know how other techniques would have worked before getting to the point of a scleral graft or putting anything in the pit. A lot of times doing a vitrectomy with ILM peeling alone will get resolution of the problem, and that can even stay permanently. So how did you know to go directly to using some sort of a patch in the pit on a first-time procedure? Or would you ever consider just doing a standard vitrectomy, and if that failed, then do this procedure secondarily?
Okay, I think in the treatment of these cases, with an outer macular hole or with subretinal fluid, maybe not in the case only with intraretinal fluid, but seems in this case we need to treat always. We need release the vitreous traction, and we need to create some barrier to allow the passage of the fluid through the pit. So maybe you can try with photocoagulation, but photocoagulation, I think the effect is more in the outer retina, and I am not sure the effect in the inner retina or in the middle layer of the retina, and you have the damage of the fiber layer. So I think putting some tissue in the pit, maybe it's better.
Yes, sometimes we can use this, but we can be more conservative. And Barbara said some ideas here that you want to share. Barbara?
The question like Tarek asked, I agree that we need to plug the pit. That's the key step of surgery. But why not to use ILM as first surgery? Why go straight to sclera? And the second question is, since you did not use ILM to plug the pit, why to peel the ILM at all?
Okay, tough questions, the two. Okay, the first one, I think I don't know about the permanence of the ILM over time. Okay, so and like Andre says, I don't know if the ILM is a thin tissue. I don't know it is sometimes not covering all the pit. Okay, and I think the sclera is a solid tissue and it's better than, and I think it's an easy approach to to take a little part of the sclera. And the other is more difficult, I think. I don't know if I took the ILM peeling, but maybe I released the tangential force in this case. I don't know it's important in this pathology or not. It's controversial, and maybe I don't know. Maybe it's
as far as choosing sclera versus amniotic membrane. Well, the sclera is already there. Amniotic membrane is easy to get, but you need to order, and it costs a lot of money, at least in private practice. So it's a good point for the sclera choice.
Thank you.
Arturo, please go ahead with your questions.
Yes, you already did an ILM rexis. So why you don't think for the first surgery to make a ILM flap, a big ILM flap, and to put the ILM over the optic disc?
Yeah, it's the same, Arturo. Thank you for the question, but it's the same that I respond to Barbara. I am not sure about the I don't have. Yeah, the sclera over time, I don't know if the ILM over time, I don't know, is sufficient to plug all the pit, and I choose sclera.
That's good. I have so many questions across the world. Like a friend from Pakistan, and he asked you if you put the patient in a posture. I mean, lay down, facing down.
Face down position? No. In this case, I not use face down position. I think with the plug, all the rest is schisis, and the RPE gonna reabsorb this macroschisis.
This is a question for Amen from Pakistan. And for finish this case, I'd like to hear Pravin comments for close this case. Please, Pravin.
Sorry, I don't understand.
I just asked Pravin Dugal to make the last comments for this case.
This is a beautiful case. You know, there's always a controversy of how aggressive to be or how minimalistic to be, and I just want to point out two things. You know, one is that there's been a great number of series that Professor Hirokata from Japan has done by doing simply a vitrectomy and an ILM peel that have got very, very good results without being any more invasive. The only other thing that I would say is that these cases tend to recur, and I think it's very difficult to judge whether a case or technique is successful until the follow-up has been for at least a year or so to see if it recurred. So it's a beautiful technique. It's a beautiful case. I just don't know whether one can be minimalistic about this and whether the vitrectomy and the ILM peel alone worked. But I don't know that we can say that a technique works until we know there's no recurrence, I think, at least for about a year or so.
Okay, thank you. Does anyone not perform ILM peeling in this case?
Sometimes I did without ILM peeling, and that's work, but it takes a long time. Just do vitrectomy, put gas, and sometimes I just do basic things and wait. If it doesn't work, I go ahead and back to the surgery and perform again. But okay, it's beautiful. Nobody knows if you should be more aggressive or not, but works beautifully. I love it. And now I thank you for your case. We need to move on because I have so many good cases. And now we're gonna ask for Pablo Chamartin for Argentina. Please, Pablo, show your case.
Okay, thank you for the invitation. It's an honor to be here. I'm going to show my case. It's a bimanual technique for retinal tractional detachment. My surgery, it's a 31 years old male with poor metabolic control and diabetes type 1. Visual acuity was hand motion in both eyes, and he has a tractional detachment in both eyes. So we decide for a vitrectomy. As we started the case, we do a 360 degrees hyoidectomy. Then we go to the posterior pole and we segmented it. After visualizing the broad adherent membranes, the decision to turn to bimanual surgery was made with the help of a chandelier. In this case, we use bimanual surgery with max grip forceps and straight scissors. As you can see in bimanual surgery, we have great exposure of the tissue. And with these broad adherent membranes, you can go fairly quickly by dissecting the planes. But you have to be very, very carefully not to pull so hard with the max grip, because while pulling up, you can do some iatrogenic retinotomies. As you can see, we still are fighting to dissect this big nasal membrane. And as we are doing this, we free it and then we introduce the vitrector. You can also use it by manual to trim down the membrane and to reduce the volume. After doing that, we segment the membrane because it is easier to approach it with when it's segmented with the scissors and the max grip forceps. As we said earlier, you have really great exposure by doing this, and you can see and create the planes on where you're working. In this case, in this surgery, we did a small retinotomy near the inferior temporal arcade. Then we did FAX, and we completed the laser under air. After that, we introduced SF6 at 18% into the eye. And I wanted to say that as a second-year fellow, I was always very anxious to do bimanual surgery. I thought you needed to be a really expert surgeon to do it, but I recommend to adopt it early because when you do that, you can avoid a lot of retinotomies and the use of silicone oil. Thank you.
Very good case. I love the tracking diabetics, and I have two friends here that's very good too. That's Arturo and Maria. And I think we start with Arturo that has very good comments. After that, Maria can finish because yes, I learned a lot with her presentation in the Pan America. Go ahead, Arturo and Maria.
So congratulations, Pablo, for your video. It's excellent. First of all, what do you think to use anti-VEGF 4 or 5 days before the surgery? That's my first question.
Okay.
And my second question is, it's very difficult to do the technique you just showed you. I think it's easy to use just one hand with a vitreous cutter with a high rate of cutters. Why you prefer to do this technique?
Okay, for the first question, we almost always use anti-VEGF in these cases from 7 to 2 days before the surgery, because you have less bleeding and it's easier to take out the membranes. And for the second questions, at the beginning, I always use the vitrector and my light or endoluminator to do these cases. But I think it looks harder than it is. Of course, you need to use your weak hand to be able to do a bimanual technique, but you can really create your tunnel or your plane where you are dissecting. And with the vitrector, it's easier to do a retinotomy. And I think when you are more experienced or you are more experienced surgeon, you avoid to do these retinotomies with the vitrector. But when you are starting, I think it's easier to do these iatrogenic retinotomies with the vitrector. And with the bimanual surgery, you can be able to avoid to do that easier, at least at the beginning. It's my opinion as a fellow.
Okay.
This was a very beautiful surgery, and I think bimanual technique is a really good technique, and it's very useful. Sometimes you cannot really dissect everything just with the vitrector. When you're using the vitrector, the main points are that you need to use a very small gauge, ideally 27. Sometimes you can do it with 25. But the principles are the same. It's finding the plane and then dissecting through the plane. But I think you made a really important point, which is why I tend to like the vitrector versus the forceps, is that it's very easy with the forceps to create too much traction and cause an iatrogenic break. So I think when you're doing bimanual, since it's not your dominant hand that has the forceps, usually it's very important to keep in mind not to pull too hard as you're doing that, because you can create breaks in the periphery. But the real issue here is that you should use whatever technique works for you, and that's very variable. It depends on cases. It depends on the experience you've had. But I always think that we underuse a chandelier. I think having a chandelier, especially if you put it at the beginning of the case, gives you the opportunity to use any sort of technique, not only the unimanual or the bimanual. So I think it's something that we should consider more. But that was a very beautiful case. And you also use gas. I really like gas so much better than silicone oil in diabetics.
Yes, I agree. Thank you for the comment.
Congrats, Pablo.
Maria always give good tips. Using chandelier is very good, and gas. And now Audrey from República Dominicana wants to have some comments. She's a very good surgery in diabetic case. Please.
Hi, Pablo. Very good case. I wanted to ask you what gauge of vitrector you were using on this case, and if you had any experience with the beveled vitrectors that are very useful on those kind of cases.
I was using 25G, and it was with the EVA from DORC, and we don't have the beveled vitrectors. And in Mexico, where I am right now, we also don't have the beveled vitrectors from Alcon or other companies. So no, I haven't used it.
That's really good. I think that your case was amazing, and we all has a lot of diabetic case, and every case a different case. You have to learn different techniques, different situations, because we need to have a lot of tools to use in different cases. And I love your case. Thank you very much. I want to move on and ask the next speaker. That's going to be Juan Pablo Franco. Juan, please introduce yourself.
Hello, everybody. Thanks, Dr. Rocha and the Pan American Society. Are you listening to me okay?
Very good. Perfect.
Okay. So I want to share the screen. So this is the patient. This is the patient that I share with corneal team. Is penetration keratoplasty, an luxated cataract extraction with scleral fixation, intraocular lens with modified Yamanic technique. So this is a 27-year-old male with a final stage keratoconus, visual acuity of light perceptions. He had an opacified cornea and the cornea showed a luxated lens. So what we did first is a conjunctival flap, then we made the incisions with a precipitated blade and a scleral pocket with a B-lance. Then the trephination without penetrate in the first stage. Use the iris hook to improve the visualization. Then we finish the extraction of the cornea with scissors. We suture a temporary keratoprothesis to perform the vitrectomy. You can see there the lens luxated, and also the degeneration, the myopic degeneration. We levitate with PFCL the cataract remove the keratoprothosis and sew the cataract. Then we thread the optics with a needle inside the scleral pocket, both of them, and the melt tip of the optic, and sew a little bit of the scleral hook. Then we suture again the keratoprothosis, and we aspirate the PFCL. And to finish the surgery, we made the suture of the donor cornea in a classic fashion. This was done also the suture of the keratoprothosis by the cornea surgeon. We make sure that the tips are inside the pocket, and then we finish suturing the conjunctiva. So this patient improved vision was not just as we wanted, but because of optic nerve damage, because also have a glaucoma, this patient. This is the patient 24 hours after surgery, 48 hours, and this is the last one that was 1 week. So that's my presentation. Hope you enjoy it. That's staff of retina department. Thank you.
Very good case, Pablo, Juan, and have many techniques to put us fixating the IOL on the sclera, and a Yamane technique is one of many people love. But I want to hear different people saying different ideas. I think Barbara want to share some ideas with us.
Well, as you said, I think the secondary implantation of IOL is one of the surgical techniques with the most variants. There are so many variants, and everybody wants to choose the one that he's used to. I was used since the beginning, 20 years ago, to use the iris fixated, so that's the one that I always use, especially when there is no cornea. It's so easy, there is no difficulties in the technique. But I think it's just an option. And many people say that iris fixated IOL can offer problems. It's an experience of many years. I chose that technique. I have nothing against this one. I think it's just one surgical option. But beautiful surgery, nothing to say.
Thank you.
I think the other guy that has a different technique that I love it is André Maia from Brazil. André, want to share the acros technique that you use it to perform?
Yes, I like to use acros suture with the Gore-Tex in patients that has no iris or the iris is not good. But if the patient has a good iris, I like to use the artisan lens, clip it up behind the lens. I think has the most reliable biometric error after the surgery. Because one of the things that I think is important is to give it the best visual acuity possible, not just to put the lens. And so you have to avoid the lens tilt. And I think these two techniques are, in my opinion, are the best, acros and artisan.
I usually perform myself the Yamane, but I love to see different techniques and learn. And the other one that I'm used to have is the hashtag that's used to cross the prolene in the middle and put the IOL. But I think Arturo wants to say something.
I totally agree with Dr. Maya said. I think that in these cases, it's better if you have a good iris. We prefer to use the same lens that we use to treat high myopia, but you have to put it behind the iris. But if you don't have good iris, I think the best technique is to put an acros lens, because it's going to be more stable. You have 4 sutures to make a better stabilization of the eye wall.
George?
Oh yeah, go ahead.
Just to finish about secondary implantation of IOL. Well, as I said, I've been using iris fixated IOL for 20 years. I have not had problems of uveitis. This is the first problem that one think about when talking about artisan lens. The problem that I had was tilting of the iris itself, and therefore tilting of the lens. Just in 2 cases I had in so many years, and I was not able to foresee the problem before surgery. So I just wanted to ask if it happened to you, to the people using the iris fixated IOL, and what should we look, because it's not so easy to detect the iris donesis before surgery in order to choose or to avoid the iris fixated IOL. Anyhow, that happened, and that patient gave me a lot of problem.
I have a comment. I use iris fixated also. I think it's my preferred technique, even though I have tried all the others. I agree with you that they remain very stable. But I think we have to be, careful with patients that use drugs that relax smooth muscles, that have the floppy iris. I think those are the cases that may give you trouble with the iris fixation. The other point that I want to make is that the Yamani techniques works really well, but you need a special lens with the haptics made of the stronger material, which, some lenses are made like that in Japan, and I know that Zeiss makes them. But the IOLs that we normally have, where I operate, the haptics are much weaker, so they tend to break. And that is a pearl that Yamani told me, and I think it's an important thing to keep in mind when you're trying the Yamani technique.
I think these iris fixation lenses are not approved in the States. Tarek, they are not approved by the FDA, no?
Well, which one, Arturo? The
artisan.
The artisan. Yeah, you're right. The artisan is still not approved for use as it has been described here in the U.S. I think we here tend to go back and forth between some form of scleral fixation technique, whether it's Yamani or otherwise. There are other scleral fixation techniques that we've described and others have. And the use of the acryos, that tends to be what people do mostly here.
Good. I think to end the case, I have Praveen has very good questions and comments here. I think he wants to share with us. Please, Praveen, go ahead.
Well, there are 2 comments really. One is, as Tarek was saying, I think in the U.S. we tend to be more leaning towards scleral fixation, Yamani or sutures. The main thing with sutures, of course, is that we tend to over tighten. And that's what causes some of the tilt that people have talked about. Barbara was talking about the tilt of the iris, but you can also create a tilt of the IOL, which really has an impact on vision by over tightening and allowing that axis to kind of move. The other comment that I would have is, look, this is just beautiful surgery. I mean, this is amazing surgery that very few people can do. But I think there's a difference between having phenomenal surgeons in the world do this surgery and giving advice that people like me and other more people can take. And the question becomes: this is a lot of surgery in one sitting. Is it a good idea to do this for the average surgeon? Is it a better idea to say, look, do it in stages, in very cases, and allow the cornea to recover first before thinking about the IOL? And although the surgery is incredibly complex and beautifully done, how many people will do this surgery in this way? Is it a better thing to do it in 2 different stages? And I think that's just a question and a comment, but that's something that I want you to at least.
The surgery, we made it with just a corneal surgeon also. So the most important thing is the team we have. So their opinion was just to do in just one surgery, but it's okay what you say. It's perfect. I perfectly understood that.
Very good. Barbara, to close the case, no?
Just a last comment to Pravin. It's a very good comment, of course. I think not having the cornea is less traumatic even for the new cornea to implant the IOL at the same time. This is something that I'm very familiar with when I treat the trauma cases from pole to pole, like Cesare Forlini used to say. And so I think it has advantages to do many steps in one surgery if we can do it, because it's less traumatic for each tissue. And you don't have to go back many times. But, it's a point of view.
Yeah, I share it.
Especially for the cornea transplant.
Very good. Juan, thank you very much for a beautiful case. Thank you, everybody, for the comments. We need to see my friend Mariano Ibras from Argentina. You have a beautiful case too, and we are continuing to learn a lot. Please, Mariano.
Thank you very much, Jorge. Thank you so much to the organization of the Retina World Congress for this kind invitation. I will share my screen, just a few. Okay. Can you hear me okay?
Perfect. Go ahead.
Okay. I'm going to share with you this case of a woman that came to us with a sudden visual acuity drop in the last 30 days. She had a severe atrophy and a Fuchs spot in her fellow eye. And at the moment that we saw her for the first time, he had 2100 vision. And with as you can see, a very long eye, an actual length of more than 32 millimeters. And as you can see there in this OCT taken at that moment, you can see a severe schisis of the retina, of the inner and of the outer layers. You can see a foveal disruption for the receptors with an outer lamellar hole and a small area of foveal detachment. So as she had a small cataract, we decided to perform a combined surgery. We first removed the cataract, we inserted the lens, and then we work on the posterior pole. We usually use triamcinolone in these cases. As you can see, the triamcinolone allows us to see these vitreous layers that are stick to the posterior pole, and it's much easier to remove them. So the first tip, I think, in this case is you should always use triamcinolone. After that, we stain the ILM with brilliant blue. Sometimes it's difficult to achieve a good staining because the contrast is not so good. There are many plaques of atrophy, and the fundus hasn't got enough pigment sometimes. So in some cases, the staining we get is not so good. The idea is to perform a peeling from the periphery to the center, avoiding the central part of the macula, sparing the fovea. As you can see, we peel just about 1 or 2 diameters in the center. And after that, we just trim the ILM very, very smoothly, trying not to drag this portion of ILM that is still attached to the retina. You must do this maneuver with a very, very low suction of the vitreous probe. Otherwise, you will get the full ILM in the probe. As you can see, we spare the fovea, we leave a small part of the ILM in order to avoid one of the most horrible complications that we may have doing this, that is the appearance of a macular hole. Because if we end up with a macular hole, the case probably we'd never get a cure. And as you can see there, the OCT of 2 months after the surgery. Thank you.
Mariano, beautiful case. And here we have one of the master of the myopic maculopathy, that's Barbara. I would love to hear her idea about myopic maculoschisis.
I'm sure Mariano chose this case just for my moderation, probably.
Yes, I was waiting for your questions. Yes.
I would not speak if George would not go. Anyhow, your post-op OCT is a very good answer because you did a great surgery, because the ILM plug on the hole was the key of the whole surgery. That was basically a macular detachment with a full thickness macular hole. Already you had to consider it like that. So, as you know, the option that I'm proposing is to use a scleral buckle, a macular buckle, and it's just, I present this just as an option because, as I said, your OCT was a good answer. Although we have to follow the patient for a long time because, unfortunately, these cases, even after vitrectomy, they might experience recurrence of retinal detachment because with vitrectomy, as you explain, you treat the inner traction from the vitreous. You could not treat the traction that comes from the elongation of the sclera and the new shape of the eye. So I strongly believe that we should treat both causes of myopic traction maculopathy, from the inside with vitrectomy and from the outside by pushing with the macular buckle. As you all well know, macular buckles are not used everywhere in the world because it's very difficult to get them and to master the surgical technique. So it will be our duty to develop a good model of macular buckle and an easier approach to surgery. But certainly I can tell you from 15 years already experience that it lasts for a long time and it can guarantee less amount of recurrence of retinal detachment as well as macular holes. I think the ILM flap answered many problems already, but not everything.
The question for when I decided to do the surgery, would you have chosen a combined procedure in this case? What would you have done? I mean, a buckle and a vitrectomy.
Unfortunately, I lost you, Mariano.
No, the question was if the choice for the surgery in this case for you would have been.
I would have done macular buckle first.
Okay.
Just to treat the schisis detachment, and then very likely I would track the patient and see if still there is a problem in the fovea that is influencing the vision. I would do vitrectomy afterward as a second surgery because that's easier. It's a shorter eye. There's no schisis, no detachment. It's basically a macular hole or a lamellar macular hole.
Okay, thank you.
Welcome.
Mariano, many people around the world is congratulate your video. That's beautiful. And I would like to hear now Derek and after that Praveen comments. And I just want to say thanks everyone here in the audience. We just crossed the line of 1,000 people attending right now in more than 46 countries. It's a great numbers. Thank you very much. But go ahead with Tarek and Praveen, please.
Yeah, beautiful case, Mariano. And I think you really got to the pathology. It's so hard to tell, with these types of cases where the greatest pathophysiologic pull is, whether it's the traction on the surface of the retina versus the elongation of the eye, and it's likely some combination of both. When I looked at your OCT and only having one slice. Of course, that's somewhat deceiving. But I would bet that if you were to get very, very histological about it, there's probably a full thickness macular hole there, at least that is somewhat small and thin, giving the vision of 2100 that you saw. And I think that probably is what prompted you to go to surgery. So I think you did a wonderful surgery to get at that particular pathology. We don't have a lot of experience with macular buckles as much in this hemisphere of the world, but I think that if I were to consider it, I would probably, at least in this particular case, Mariano, do as you did, which was to do the vitrectomy and try to take care of the traction and probable hole. And then were it to fail, then maybe would consider other options like even macular buckle among other choices.
Yes, you know, in pre-op, sorry, Pravin, go ahead, please.
No, I was going to say that like Tarek was saying, like everybody around the world said, that the surgery is just absolutely beautiful. I think what the main points of the surgery are that if you're going to operate on patients like this, also like in patients who have diabetic retinopathy, the staining of the vitreous is terribly important because of the speed of the vitreous cavities, and I think that's a very, very important lesson. The other really important lesson that you clearly showed is not to be terribly aggressive about removing the ILM. The way that you did that to leave the roof on top was really important, and I think people need to realize that the key here is that the ILM becomes sort of a platform for traction, and if you go ahead and remove the reason for the traction by doing this circumferential dissection, it's okay to leave that little cap there and not risk pulling off the roof to create a macular hole. Now, beyond that, look, Barbara has more experience with this type of surgery than anyone else in the world. But what I would say is, it's not clear to me that all of these cases are the same. There's some wonderful surgeons with great experience where they don't do a macular buckle and you have great results. There are other surgeons like Barbara and others in Spain and elsewhere who will advocate the macular buckle. I'm sure they've got great experience and they're all correct, but what we really don't know is, are all these cases really the same, and ought they to be treated the same way? Is there a threshold whereby you get that balance between the internal pathology and the external pathology, where you may need it for the internal pathology in some cases, but external pathology in others? So until that's clear, and I think the answer is going to come to us now with different techniques of OCT imagings, we just won't know. And the last thing that I would say, as Barbara alluded to, is that, look, this, like in a lot of cases that we've seen, we don't know what the final answer is of success until we have a long follow-up and know that it's not going to recur. So I think we also have to be very careful in judging techniques without follow-up that's at least a year or even longer. But having said that, look, there are a lot of great lessons here, Mauricio. This is a fantastic case and beautifully, beautifully shown. Thank you for sharing.
I'd like to ask a question that's from the audience that's addressed to Barbara. The Pablo Vaquero from Mexico just asked Barbara, what kind of material you use for buckles, like titanium, sponge, whatever. What's your preference for buckles, macular buckles?
So far, since we don't have a good commercial product, I am using silicone and titanium, but I don't want to take any attention from Mariano's video with this answer. I would like to give you my email, parolini@gmail.com, and I will give you all the answers on buckle. He did a great surgery,
And some friends from Brazil, like Francine Vega, ask Mariano, what's the good tips you're gonna address us from this surgery? What's you learned that you want to share for everybody for this kind of myopic maculopathy?
Okay, first of all, as Pravin said, always in these cases use triamcinolone. Sometimes the vitreous is not completely detached. You find like vitreous cases. You find different layers of the vitreous, so it's very important to use triamcinolone. Another tip is to stain, and if you don't see, you restain because the contrast is bad. Usually the fundus is clear and the staining is not good. So if you don't see very well, you should stain and restain many times until you find the right place for the dissection. And the third one would be not to be aggressive. If in a case of this, where you do not have a macular hole, you create a macular hole, you will end up with a very difficult problem. So I would say try to be as conservative as possible, go slowly from the periphery to the center, and try to avoid being too aggressive.
Very good. Thank you. Your case is showing so many questions here, but I can't apologize for all the work because I can't make all the questions because we have limited time. But I thank you everybody that's sending us questions that we're gonna try to answer after the show. But right now we're gonna move. Thank you very much, Mariano. It was a great case.
Thank you.
I'm gonna spend all day just discussing your case here. Got it starting here, but right now we're gonna move to Audrey. That's gonna show us a beautiful case. And Audrey, please introduce yourself and start your case.
Hi, thank you so much. It's a great honor for me to be here today in this film festival with all these excellent surgeons. So today I would like to present suprachoroidal buccal for rheumatogenic retinal detachment. So this is a case of a 35-year-old female who has past history of retinal detachment on her left eye 12 years ago, treated with scleral buccal and cryo. She referred decrease of vision on her right eye, 2 months of evolution. She had a single hole in the superior temporal side of the retina with macula off. She was complaining of foreign body sensation and discomfort of her left eye, and the buccal was visible subconjunctival temporally. So we decided to do a suprachoroidal indentation and cryo of the lesion. For this, we realized a peritomy in the side of the hole, cauterization of the sclera vessel, and then we place a chandelier light in the opposite side. Under direct visualization, we did cryo of the lesion. A paracentesis was done to avoid increase of the IOP during the injection of the suprachoroidal space. 4 millimeters to the limbus, we did a 3 millimeters incision to introduce the olive tip cannula 23 gauge designed by Dr. L. Reyes. Again, under direct visualization, we inject hyaluronic acid or viscoelastic until we get the desired indentation. Then the wound is closed and the conjunctiva is sutured. 3 weeks after the surgery, the patient presented with better visual acuity. The indentation was still visible and some remnant fluid under the fovea. 3 months after, the retina is fully attached, the lesion is still, and the scar looks fine. Thank you for your attention, and a special thank you to all the retina service in my hospital, Dr. Elia Santana here in Santo Domingo, Dominican Republic.
That's a real beautiful case. This technique that's use a suprachoroidal buccal and work beautifully and very elegant. And I would like to hear people that has more experience than I have no experience. I never did that before, but I will try for sure. And now I've heard, Maria, do you have any experience with this and have any comment?
No, I don't have any experience with that, but this was a very, very elegant and beautiful case, actually. But I do have a question. You injected hyaluronic acid, Elon? Is it required to only use that, or can you comment on that?
Well, we have tried different substance. First, we start with a cross-linked hyaluronic acid that stay way much longer than hyaluron-5 in the eye. Cross-linked hyaluronic acid can be causing the irritation until 3 months. However, hyaluron-5 just lasts around a month, 3 weeks, 1 month, more or less. But both works.
Beautiful technique. And do you use illumination in the cannula as it's going in?
So no, I have the olive tip 23 gauge cannula. There is another one, I think it's a 30 gauge cannula that is illuminated, but this is not the one we have. The illuminated one is way longer and much smaller, and it's preferred for macula indentation that Dr. El Reyes also has described, but I haven't done this technique for macula case.
Wonderful. Thank you.
Audrey, I have a question for our audience. That's Eduardo Keltman from Brazil. Yes, pneumatic gas versus your technique. Why you choose one versus the other?
Okay, criteria are close. However, this technique is really good for inferior breaks. This is not the case I present. However, it works really well in inferior lesions. And in this particular case, the patient lived in the city in mountains. So we didn't want to use gas bubble. And also she was complaining of discomfort of conventional scleral buckle in the other eye. So that's why we choose that option for her.
I agree. And Praveen, do you have some comments that you want to share?
Yeah, I think this is a fantastic case, Audrey, and it also kind of shows us where we're going in general in retina and ophthalmology, which is that I think the suprachoroidal space has been extremely underutilized in general, and we're just learning about it, not just in terms of surgical techniques. And I think Ihab El Reyes has really been the person that's really taught us this, but also in terms of drugs and medical usage, like for instance we do with the clear side needle and so forth. We're even doing gene therapy in the suprachoroidal space. We're looking at that now. So I'm just wondering, Audrey, in the future with this kind of technique, whether it's something we could be combining the surgical with the medical, and perhaps with a needle like the clear side needle, be able to isolate where the breaks are and actually inject substances such as the hyaluronic acid and other things in the office in order to treat these kind of detachments. And I think that would be fascinating to just think about what we can do with the suprachoroidal space in the future. So thank you for sharing this.
Thank you. Yes, I think it would be amazing in the future. I brought this case because I want to enthusiasm more people to try the technique. I just have maybe one recommendation. First, I start doing it combined with vitrectomy, so I feel safer. And then with the experience, I'll start doing it alone, with or without external drainage. But I just wanted to show you, and I hope that more people will try it.
I have some comments from Tarek.
Yeah, it's a beautiful case, Audrey, and it's nice to see that technique in practice. I agree, it's not really been adopted quite as widely, I think, as the inventors would have initially hoped. And I think the only reason is really has been, at least till this point, some fear and the idea that if they were going to the operating room, that they may as well just do something that they're more comfortable with and is more invasive, like a vitrectomy. I think the idea that possibly expanding our use of that suprachoroidal space and possibly moving this type of surgery into the office could really open up a future for this technique. I've been advocating for a move to office-based retinal surgery in many situations for quite some time. And we get closer and closer and closer as the years go by with improvements in technology and a reduction in fear. And this type of case that you showed, which was so lovely, can demonstrate, the ways that we may be able to fix things in a way that is less invasive than what we've been doing, and potentially even in a safer manner than what we're used to. So very impressive. I have not had a lot of personal experience using this technique, but I think finding a place for it in all of our armamentarium of techniques is going to become important with time.
Audrey, want to?
Thank you all for your comments. I think, yes, it's a great opportunity in the future. Maybe if we can do these kind of procedures in the office. And I think I want to explore more the suprachoroidal space. And there is a lot of things we can do, as you all have said, in this space. So let's keep on.
Thank you very much. Many people are saying congratulations for your video, like the Christine Patel from India and friends from Pakistan. And thank you for sharing this video. That was great. And now I'm gonna move on for my friend from Brazil, André Maia, one of the best surgeon, vitreoretinal surgeon in the world. And I want you to share your video, my friend.
Thank you, my friend. I'm just going to show you a little piece of a video, just because we're talking about intraocular lens fixation. This is the aqueous view fixation viewing from the endoscopy. As you see here, the lens is here, and that's a Gore-Tex. So we have this discussion just a little ago. Just I'd like to show you this little piece of video, which is very interesting. So I think one thing you should do is, after the implant, take a look with endoscopy and take a look if everything is fine. But that's not the case I'd like to present. The case I'd like to present. Can you see it?
No, you must share your screen before I start.
Oh, sorry. Okay. Okay,
Perfect.
now I can see that. Good. So let me show the case. So this is a 50-year-old man that he had a recurrent vitreous hemorrhage and glaucoma on the right eye. He lost his left eye because he had the detachment a few years ago. The best corrected visual acuity was 20/40. The intraocular pressure was 19, and he has a posterior chamber intraocular lens in the sulcus. That's his refraction, -4, -1 on 180. And that's the biometry. He is supposed to have a lens with a 0 power. He has this dome-shaped maculopathy in both eyes, and the angiogram shows no ischemia. But the UBM showed the optic was touching the ciliary body. That's why we thought it could be uveitis and glaucoma and hyphema syndrome. So high myopic patient, dome-shaped maculopathy, pseudophakia, and uveitis, glaucoma, hyphema syndrome. So we decided to do a partial vitrectomy and remove the intraocular lens. And that is the case. So we have to open the eye to remove this lens. We did a 23 gauge vitrectomy. As you see here with the endoscopy, it was very nice to see the optic of the 3 pieces lens touching the ciliary body. And we thought that could be the cause of this recurrent vitreous hemorrhage and recurrent glaucoma. So I think in this cases, endoscopy, it's very interesting and very nice tool to have. As you see here, the same thing on the other side. So we proceed with the removal of the lens and the capsule and all the fragments from the posterior part. And after that, we took a look with endoscopy just to see if everything was fine. And with endoscopy, it's also possible to see the trabecular meshwork. So we decided to proceed with
vitrectomy, remove all the fragments from the posterior part, and we suture. And after that, we put this eye stent implant just to reduce the pressure, intraocular pressure of the eye. So that was combined procedure, pars plana vitrectomy, lens removal, and glaucoma surgery for a Hugh syndrome. And we close the conch with the T-cell glue to avoid suturing. So that's the final result. Here? Good.
Very fine case, my friend, of uveitis, glaucoma, and bleeding that you approach very well. And I heard Pravin that has some comments here.
So this is a wonderful case, and thank you for sharing that. And the endoscopy is, I think this is one of those things where the endoscopy tool is more important than anything. I just want to share this with you. I think the cause of the entire thing is the retained lens material. And I know of 2 patients that I have who unfortunately have been under treatment for chronic uveitis with immunosuppressives, et cetera, for decades. And ultimately what they ended up having was not any kind of uveitis that one would think of that requires immunosuppression systemically, but ended up having retained lens material from cataract surgery years ago, where there was a little bits of the cortex that was left under the iris that nobody could see. So I think that this is a big issue that very few people talk about. And I really think that the reason for this entirely is the retained cortical material, which causes the inflammation, which causes the fibrosis, which causes what appears to be UGG syndrome. I'm not sure this is a typical UGG syndrome. It may be UGG-like, but I think it's the retained lens material that's the causative agent here.
One thing I think is very important to do is UBM before the surgery, just to be sure that everything is fine. And also angiography, I think that's nice because sometimes you have a patient with the vasculitis and uveitis that has nothing to do with the lens. And so I think angiography could help us in some certain cases. And in this particular case, we didn't see anything particular. So we're okay just to remove the lens and the capsule. And we didn't do any secondary lens implantation because with the biometry, the patient is supposed to be 0 after the surgery without any lens. So we just left the patient aphakic.
Yeah, I think the key here is that if there's any case that anybody does with retained lens material or for uveitis in a pseudophakic patient, I think it's really important that we instill upon everybody that they should do a very, very good depressed exam to look far in the periphery around the ciliary processes to see if there's any retained lens material there as well.
Thank you.
Good. Marcelo Zaz, I want to share some comments too. He was discussed with me in private here. Marcelo. Marcelo Zaz, can you hear me?
And now, can you listen to me?
Yeah, for sure.
Okay, thank you, George. Congratulations, Andrea. This is a very nice case, beautiful, amazing case. I think you showed that endoscopic technique, not very common on ordinary use in the world because of the technique of learning curve or the to get to the machine. Show us here beautiful intra-op images just to get where the optic of the lens is, where you have to be more efficient in the surgery. I'm with Pravin again when he's talking about the fragment of the lens in vitreous cavity just to get inflammation. But the endoscopic technique is a very, very useful tool in this kind of cases. And I want to congratulate you for the useful on the show us sharing this kind of technique with us. Thank you.
And Barbara, please.
Yes, I just meant to say that not just uveitis, but also recurrent vitreous hemorrhage should, in pseudophakic patients, should induce us to think about the IOL as a cause. I had a patient like the one that Andrea described. He had received 3 vitrectomies, pan photocoagulations for recurrent hemorrhage. and he kept having hemorrhages. So I took it back to surgery. I did not use endoscopy because I don't have endoscopy, but even with strong indentation and lifting the iris, I could see that the aptic was inside the ciliary body, removed from there, and the patient was fine. So it's one of the cause of recurrent vitreous hemorrhage.
Andre?
Yes, I think sometimes we as retina specialists, we have to deal with the difficult cases, especially patients with glaucoma, secondary glaucoma, uveitis, and we have to think about that as a primary cause of the glaucoma and uveitis, especially in patients with unilateral diseases. So I agree completely with Barbara. So nowadays, when you think about this disease, we have to do a proper examination, UVM, and sometimes just take a look inside the eye with the endoscopy or remove the lens if there's any doubt, because I think PRP and anti-VEGF doesn't solve the problem. And I think she's completely right. I've been seeing cases like this for many years, and I think most of them are missed diagnosis.
That was a very beautiful case and very elegant approach for vitreal hemorrhage, recurrent vitreal hemorrhage, and uveitis. And you show us very good technique with endoscopy. I thank you very much for sharing us this beautiful case. That's wonderful. And now we're gonna move on for the next case. That's gonna be another friend from Brazil, Anderson Teixeira. Anderson, please introduce yourself and
hello, everybody. It's a pleasure to be here. Thanks, Tarek, Arturo, George, and Marcelo for the kind invitation. It's a special case because I have to program my surgery using parameters close to normal eyes and optimize the maximum of the machine and the instrument for that. So let's start it. A male Caucasian with 53 years old in treatment of exudative AMD using anti-VEGF injection, and he complying low vision 6 weeks after the last injection. He got a eye surgery in his right eye due to a massive vitreous hemorrhage secondary to AMD, and he never recovered the vision after the surgery. His visual acuity was hand motion in his right eye and 2400 in his left eye. Those color photos shows when we started his treatment with improvement of blood with a recovered vision. So 6 weeks after his last injection, he came with a peripheral and central vision loss. He got a superior retinal detachment with invisible breaks during the exams, and that occurred in his best eye, with the best of massive vitreous bleeding in his right eye secondary to AMD. So I decided to perform the surgery. My program was perform exploratory postplantar vitrectomy, but be prepared to no hematogenous or hematogenous retinal detachment. Adding that, we have to be aware to not causing the bleeding during the surgery or after the surgery. I have just got AMD surgery. So I perform a 27 gauge postplantar surgery using valve trocar, and I have to maintain the system pressure with 25 millimeters of mercury. During my indentation, I found the temporal superior breaks, and I used the probe to drain the subretinal fluids with the hose of the breaks. I think that's one of the advantages of the 27 gauge surgery. You can use the probe to drain the fluids, and drain it's very smooth. And the retina can be repositioned with safety without using a heavy fluid or air fluid exchange. After the laser, I decided to leave the eye with just only air. And the patient got the final visual acuity with 20/80. Before I open the discussion, I would like to say thanks very much for the invitation, and I'm very honored to be part of the Pan American Retina in the World Retina Congress. And I had a lot of friends over there. And with this pandemic, the pandemia give to us just talking in our house, but we still closed. We're using this kind of Zoom. This Zoom or this kind of internet toys. Did you guys see my invitation, or did you guys see my video or no?
Yeah, it was great. I could see everything. Very good case of retinal detachment in a only eye. And I'd like to ask comments from first Arturo, after that Maria.
I've got an issue here. I cannot.
Arturo?
Yes, first of all, congratulations for your video. And I'm being used the 27 gauge proof for a while, and I think it's very useful, not for what you show, but also for diabetic retinopathy. I think it's the best instrument to do the surgery. But going back to your case, I like very much what you show, and it's another way to take out the fluid from the subretinal fluid. Also, you can do it with extraction cannula without using the proof. But it's a nice procedure, and I don't have too much more to comment.
My big afraid of this case is because the patient lost his eye with exudative vitreous hemorrhage because the AMD, exudative AMD, and I was very afraid to change the pressure of the eye during the surgery, or to avoid really some bleeding after the surgery, postoperative surgery. That's why I think we should consider to work with low pressure in this kind of case.
Yes. Yeah, I think this was a beautiful case. And as you all know, I really like 27 gauge. And now with the 20,000 cuts per minute that is available in several of the vitrectomy machines, it is actually very fast to remove fluid. And I also like draining with the probe. I think it simplifies matters. But I think your case underscores some really important points that we should all keep in mind, which is that if we remove all of the traction around the brake, we really don't need a long-acting gas. Air works just fine in those cases. And especially it being a one-eye patient, you should use the shortest acting gas possible. Also, in cases like this, injecting anti-VEGF just a few days right before the surgery is useful, just to stabilize the situation in the back of the eye. The other thing that I would have considered in this case is maybe putting a sponge buckle. I think those work really well. I like doing those, just a piece of segmental sponge in the area of the brakes. You can do it with cryo, or you can just do laser afterwards, or do laser in the office, or you can do it with a chandelier buckle. And it's a really minimal technique that also gives you the advantage of having the patient be able to see and not have a long-acting tamponade. So, there's a lot of ways we can use a suprachoroidal buckle if it was only a brake, but there was like several brakes, as you mentioned. So I think this really, your case beautifully shows a lot of these important concepts in retinal surgery. The thing that is surprising, though, is that this patient was only, in his 50s and already had this very advanced macular degeneration, which I thought was unusual. If you have any comments about that?
Thanks for your consideration, Maria. My first choice, if I found the brakes, I should do a sponge or a sclerobuckle, because I believe the vitreous is still keeping the lifetime of the anti-VEGF injections. But I didn't find. I was very considerate to get a no rhematogenous retinal detachment. That's why I choose to perform the vitrectomy.
That's good, and it's very good thoughts about the positions of the patient. Please, Pravin.
So, Anderson, very, very nice case.
Please turn off your phone, your microphone, please. Marcelo Sass.
Anderson, that was a very, very nice case. The only thing that I would say, I mean, you obviously have many advantages there, which is that you don't have to use PFO. You have a much shorter case. You don't have to make another hole to drain, and so on and so forth. The only thing that I would say is that if one is going to use the existing holes, I mean, first of all, you got to find it. That's the important thing, and not create a bigger hole. But what Maria said is very important, which is to make sure all the traction is removed. But the final thing that I would add is that it's also very important to make sure that you position the patient properly. In the rare cases that the patient positions in such a way as to get a retinal fold, it becomes a real disaster. So if you're not going to use a PFO and if you're not going to use a retinotomy to drain, it's really important to think about positioning the patient properly post-op.
Yes, you're very right, Parveen. You have to avoid the folds after the surgery. It's one of the cases.
Anderson, very good case. Thank you very much. It was beautiful. We learned a lot. But now we have my friend Marco Vidosevich from Argentina. Marco.
Thank you very much. I share the screen. Wait me a second. That's okay. Good morning, everyone. Before starting my presentation, I would like to thank the RWC for the invitation. Today, I would like to talk about the 3 cases of severe fractional detachment due to PDR and the different approaches I use to repair them. I generally prefer to use a contact system with chandelier so I can have the option of working with the bimanual technique. In the first case, I used an available 27G 10K proof, which facilitates finding dissection planes and interior easier under the fibrovascular tissue with high cut rates. This results in a faster surgery with less bleeding. In these all cases, we use the anti-VEGF 3 days before the operation. In this second case, I'm also using 27G proof and a bimanual dissection technique, with the forceps in one hand and the vitrectomy proof in the other. In the case of finding the correct spot between the retina and the fibrovascular tissue, a good alternative is using a manual way. When whole retina is free of traction, you can make the fluid exchange to retachment the retina to prepare to use laser, and at the right time on it you decide. Finally, in the third case, I using a 23G vitrectomy proof. I started first removing all the anterior traction, and then using again a bimanual technique. In this case, you see with forceps and scissors. Once the tissue has been removed from the surface of the retina, put PFO to stabilize in the posterior pole. And it can be decided whether to put gas or silicone oil. That's all, and thank you very much for your kind attention.
Marco, very good case, very good techniques. You combine the probe and bimanual, and we have 2 good friends to comment this. They're Arturo and Maria Berrocal. And
Sure.
Arturo, please.
This case is very similar like the case that Pablo Chamartin showed you. One question, Marco. When you prefer to use gas or when you prefer to use silicone oil in these cases?
Yes, thank you. It's a good question. I think the best option in these cases normally use and prefer gas. And when I finish my surgery, sometimes I put VEGF into the eye and finish with gas. I prefer gas in this because the inflammation is too hard, too strong in this patient. And I think it's the less inflammation in a post-op.
Okay.
Yes.
Go ahead, Maria.
What do you think, Maria?
No, I think beautiful cases, Marco. I think it's really important that you show this because it really underscores that we can use different techniques and different platforms to achieve success in many of these cases, because you showed 23 gauge, you showed 27 gauge, you showed unimanual, you showed bimanual. I think, the points that you made are very important for everybody to keep in mind, which is these were very bloody cases, even though they were pre-treated with anti-VEGFs. So just imagine if they hadn't been. The other thing that I think we should always keep in mind is the patient's systemic blood pressure, because many of these patients have really uncontrolled blood pressure. And if the anesthesiologist is not keeping tabs of that, they tend to bleed, even if we pre-treat them, bleed a lot. So just little things to keep in mind. I also think that at the end, sometimes adding anti-VEGF in the very bloody cases is very useful. I also think that gas is much better, especially because if they rebleed, we can do a fluid air exchange in the office and avoid taking them back to the operating room, which I think is also of benefit. I think using the chandelier from the beginning in these very complex cases is much better, because that way you're ready for whatever entails. In these cases are very unpredictable. And I think, as you showed, the main thing is to just be comfortable with a lot of different techniques, so that as the case evolves and unprecedented things may occur, the patient moves, the patient starts bleeding, you create a break, you have the full armamentarium of things to do. So they were very beautiful. So thank you, Matt.
Thank you. Excellent, your comments.
I have also very good comments from Pravin and Tarek. Please, you two guys, go ahead and make your comment. That's very important. I think a long time ago, I learned from Pravin to do vesicle dissection, and he wants to share some ideas about that.
Well, I think one of the things, a beautiful case, by the way, just beautifully done, as usual. One of the things that I would consider, again, it's important to have a whole bunch of different techniques, but one of them is reflux hydrodissection. And you can do that with the machine itself, where there's proportional reflux. The nice thing about injecting a fluid there is that you don't have to remove your hand, bring anything in there. But remember, there are two things here: that the fluid will press down and the retina, the normal retina, but also press up the fibrovascular tissue. So it just creates enough space, especially if you're using a 27 gauge, to engage your cutter and remove the fibrous tissue. So it's important to remember that technique. But the other one also that I think we should think about sort of bringing back, because it's been around for a while, is viscodissection, especially in cases that are particularly bloody, because it's not just that it creates the separation, but it also creates a tamponade to a certain extent. So I think in addition to everything that was said, it's important to remember that, what I try to do in these cases is, my way of thinking is I do everything possible to try and avoid silicone oil. And that means that I do whatever I can to not create holes and tears myself. These patients do terribly, the diabetic patients, with silicone oil. And if there's something that I can do, even if I leave some tissue behind, be it with pegs, but not create holes, and just relieve traction and not try and be too aggressive and avoid using silicone oil, I'd consider that a success.
Pravin, what kind of visco do you prefer nowadays to use this technique?
I would use one of the whatever you have handy that will last for as long as you can. People try different things with different things. I mean, I prefer Helon. That's sort of the compromise for me. The thicker ones, I think are a little bit more difficult to remove. The thinner ones don't last as long. There's a compromise somewhere in between. But again, it's a preference thing.
Thank you. I have some question from audience. Marco, a friend from Brazil, Marcia Ishivac, ask you if you do some peeling, internal limitant membrane peeling at the end of this bad case.
Yes, I understand. But in these cases, it's a very hard cases. I don't recommend. It's very difficult because the retina is detachment. So if you doesn't have a retinal detachment without PDR, maybe it's an option, a good option to do it.
Very good. And Tarek, your final comments for this end of this case?
Well, I think that the video was beautiful, Marco, and I agree with the comments made to this point that emphasize that we do have many techniques and we should try to learn them all to get at the root cause of these problems. You know, these types of traction retinal detachments have traction that comes from all different directions, but the underlying concept in these types of surgeries is that you have to relieve the traction at the level of the posterior hyaloid. So that involves removing it from retinal surfaces as well as from the surfaces of fibrovascular proliferation. So sometimes we need some or all of those techniques to do that. And I think they all are important. One issue I tried viscodissection at some point years ago, and the concept of pushing and pulling the surfaces is important, particularly when you're trying to control something where there's a lot of bleeding. But I am concerned a little bit about the pushing force with the viscodissection part of it, because you can push down layers of the hyaloid. We know that in these types of cases, vitreoschisis is very common, and we'll often see that the posterior hyaloid really has multiple layers. So I think it's just very important to make sure that with whatever technique you use or combination of techniques you use in these cases is to make sure the posterior hyaloid comes up, and that will lead to the ultimate resolution of traction and hopefully keep these cases without the need for oil or recurrent surgery. I think someone presented the cases earlier today, which is something I like to do, which is to, if you're fortunate enough to have the hyaloid elevated anteriorly, is I like to do a circumferential hyaloidectomy, as it was called, to relieve traction from and separate the traction that is anterior from that is in the posterior pole. Again, trying to better manage the hyaloid in all of its attachments. So beautiful video that showed all of these concepts.
Thank you. I'm agree with you. Thank you. In all our concepts.
Very good ideas and concepts. And for the end, I think my friend Andre Maya wants to make some comments about the use of VEGF before and after the case. Andre?
Well, I think most of us use anti-VEGF before a case like this. The question is if you're going to use 1 or 2 or 3 days or 1 week before. I particularly use 1 or 2 days before, but the question is after the surgery. And I've been seeing cases that after the procedure, even with a full PRP, a perfect surgery, the patient, they end up with a neovascular glaucoma. They have rubeosis, the intraocular pressure starts to rise. During this period of postoperative, there is a lot of inflammation. So I believe we should, in certain cases, inject anti-VEGF to reduce the risk of neovascular glaucoma after the surgery. That's another thing I would like to ask the rest of the panel. What is the role of anti-VEGF in a case like this?
That is a very good point, Andre, because I have seen that. I have had patients that I leave completely beautiful, full PRP, and then they develop rubeosis. They don't have any, detached retina or anything like that. So I think that is a very good point. I think on these very severe eyes that had very severe ischemia, sometimes we don't do an angiogram before the surgery because they have blood and they're detached. But if we do angiograms afterwards, we're going to see a lot of severe ischemia. And I think that is a very good point. And I think that is something that we should consider, just longer term monthly anti-VEGF until all the inflammation is gone and the patients are stable.
Very good point. And one last question for you, Marco, from India. The friend for Duva Voha, he asks you when you remove the fibrovascular tissue from the optic nerve and start bleeding, what you do to stop this bleeding?
It's very difficult. It's very difficult. So the secret for me in these cases is do it faster as possible, because if the bleeding a lot, it's very difficult. It's tough to the retina. It's depend. You can make a different option to get out the hemorrhage or the bleeding. But this is a problem. It's a very big problem in these cases.
Usually,
sometimes you can increase a little bit the intraocular pressure to avoid the bleeding.
Yeah, sure. It's an option.
Another option that I use is to a drop of PFO overneath the optic nerve, and after a while it's gonna stop, and when you're gonna go for the gas through the chain.
It's a good option. It's a very good option. You put the PFO to stabilizing the bleeding, and it's good. But it's very difficult when it happens. It's very difficult to have different types of do it to don't bleed in more. Like say Arturo, I'll take one with PFO.
Another thing that you can do, which I have done sometimes, is when you see the bleeding part of the optic nerve with the vitrectomy probe, you can just press on the vessel, keep the pressure up, press from the vessel for about half a minute or a minute, and oftentimes, that stops the bleeding. Like 20 years ago, before we had small gauge, Klaus Eckert came up with a heme stopper, which was an instrument that was just a ball at the end to precisely do that, but you can do it with the vitrector. You just aspirate there so you can see actually the bleeding vessel and just press on it.
That's true, Maria. I learned that technique from Maria, and it's very useful. With the vitreous probe, you can make some pressure over the vessel, and most of the time it stops the bleeding.
Very good. That's the beautiful thing to have so many good specialists together. We have so many good tips. You learn a lot, and sometimes I have to think that you have limited time to discuss so beautiful case. Thank you very much. Marco was beautiful. But the last, not the least, my friend, my very good friend and tremendous retina specialist, Marcelo Zayas, is gonna end this section with a very good case. Go ahead, Marcelo.
Thank you, Jorge. It's a really honor for me to the Retina World Congress and the Pan American Retina Society in this moment to join all this effort, our knowledge in this situation. And I'm really honored to be invited to all these expert of panels and friends around the world. I'm going to, can you see my screen?
For sure.
Okay. Massive submacular hemorrhage is a potentially devastating complication of certain retinal diseases, particularly neovascular age-related macular degeneration. As all we know, the pathophysiology of the accumulated blood in the subretinal space is thought to involve impairment of nutrient exchange between the RPE, the outer retina, mechanical damage to photoreceptors during the clot contraction, and possibly iron toxicity. We present in this video a monocular 90-year-old patient who presented with a subacute vitreous hemorrhage to a massive submacular hemorrhage on his left eye. I'm showing my routine technique with 25J of trocars, valve trocars, 450 of vacuum, 4 and 5,000 cuts per minute. You can see the overlay, all the values. The ocular pressure was set in 30, 35 to avoid intraocular bleeding. So first of all, we began to take in all this vitreous, to clean the vitreous cavity in vitreous vase, the central vitreous, just to get and to watch this very, very big submacular hemorrhage secondary to EMD in 90-year growth. You can see here the thicker zone is where the temporal arc is. So our technique is to inject the TPA, anti-VEGF, and filter air using this kind of very useful cannulas. There are 25 or 30H. You can use the 25 or 41. It depends when you have. with the viscofluid inject, with the viscofluid infusion mechanic with the Constellation machine. You can see the bubbles under the retina just to mobilize and to do the liquefaction of the very good clot. There's a secondary, this is the second retinotomy in the inferior retina, where the retina, it was all very thick. You can see the bubbles moving, and this was the last retinotomy in the posterior pole. After that, we do a pneumatic displacement with a complete airfoil exchange with 20% SF6. And here you can see very clearly the pre-op, the intra-op, and the post-op, and you can see the EMD was the physiopathology of the submacular hemorrhage, the gas bubble in the superior quadrant, and all the displacement in the periphery of the retina with the visual acuity with count fingers on the post-op in 15 days in follow-up. So in conclusion, surgical intervention for massive submacular hemorrhage from AMD may lead to anatomic and visual improvement, regaining ambulatory vision, and you have to choose the patient and choosing the time to the situation. Thank you so much for the invitation. Thank you.
As I said, was the last but not the least. Beautiful case, my friend. And for comment this, I will address Pravin. After that, Barbara. That was good guys from macular surgery.
So again, a beautiful case. Thank you so much for sharing this. A couple of comments. I think when we look at the surgical indications for submacular hemorrhage, I think we have to separate into two different categories. One is with vitreous hemorrhage, and the other is without vitreous hemorrhage. I think with vitreous hemorrhage, obviously, that takes an entirely different connotation, because now the patient really can't see at all, especially if they're relying on that, and you have to remove the blood. And if you're going to remove the blood, do you make an attempt to go ahead and remove some of the submacular blood as well? And if so, how? So I think that was a beautifully shown case. Now, in cases where there's no vitreous hemorrhage, I've got to tell you, my thinking has changed a little bit. In the beginning, I used to think, if somebody comes in with some blood under the macula, no vitreous, but just under the macula, and they come in early, within 3 days or what have you, I'm going to go ahead and do surgery. I've really been impressed with a lot of cases that have been shown to me by my friends and colleagues that I've done as well, where you just go ahead and inject with an anti-VEGF, and they actually do quite well over a long period of time. Not everybody, but a lot of them do. So my definition of what's a massive submacular hemorrhage that warrants surgery is changing over a period of time. The second thing that I would say is that if you do decide to do surgery, I do think the best technique is one that Tamer Mahmood described when he was in Duke some years ago, which is to inject, as you did, the filtered air as well. I think the surface tension that creates between the air under the macula with the air fluid exchange allows it to be pushed out in a squeegee manner. And I think his technique is the best one that I've seen, which is what she used. It's a beautiful case, but thank you so much for sharing that.
Thank you, Praveen. So also, if you say, there's a very nice paper of people from Brazil, Dr. Novelli, was published in Retina in 2017. And as you say, it separates if the submacular hemorrhage has vitreous hemorrhage or not. And also, if the massive submacular hemorrhage was small, maybe it's thick, but it's small, you can inject TPA and gas, and that's it, and the case will be fine. But if with your hand in the great position and put it with a 25-38 or 25-41 gauge under the retina in the safe way, and you will be a success. So you can do it. It depends on the case in both ways.
Very good. And Barbara, I want to make some comments.
Yes, thank you. On this particular case, I think you made the right choice, and that was the right thing to do. And I agree with the comments that Pravin just made. I think the observation of the preoperative OCT is the key factor in choosing the best technique for these cases. First of all, we have to look at the position of the hemorrhage, whether it is just under the retina or retina and RPE, because that creates a change in the prognosis and in the indication of this type of surgery. Second, in this case, the external retina was already damaged. It was an advanced stage of AMD. If the external retina was, let me say, in a better shape, in a good shape, then I would have given the indication of choroidal transplantation, because the chance of visual improvement is good. Of course, it's a very difficult surgery and not everybody is able to do that. It needs a long training, but it is a good option only if the outer retina is in a good shape. A comment on the technique as far as injecting subretinal fluid, whether it is to detach the retina or to dislodge the hemorrhage, we have to insert the needle as far as possible from the fovea, because the biggest risk is to induce a macular hole when we inject. And so the whole point of surgery might be put at risk by a iatrogenic macular hole. So it is very important to stay away from the fovea.
Thank you, Barbara. I agree with you. So you usually want to inject, maybe the key point is to inject when the retina is thicker, because when you inject air and liquid and TPA, you get immobilized of all the air fluid under the retina. So you don't need to go to the fovea. You have to go to the thicker zone just to be safer, and you get to mobilize the clot with liquefied with the TPA. I agree. Thank you.
Marcelo, a question for the audience, and a friend from Brazil, Aline Rupert, she asked you the concentration of TPA and the amount of volume that you mix TPA and VEGF.
Yes, because we use the usually doses of anti-VEGF when you do anti-VEGF therapy in diabetic macular edema, the same doses. And the TPA now in Argentina was a problem in the past, but now we have some stores, some pharmacy that prepare the concentration of the volume, exactly what we need to inject inside the eye. So there's the preparate for us. So we inject 0.1 millimeters of TPA.
Excuse me, do you have any experience with other substances like heparin, Clexane?
No, we don't have, Barbara. In Argentina, we don't have. All the literature teach us about the TPA, and now we're lucky in Argentina because we can buy the dose exactly to put inside the eye, not to buy. So the very big bottle was very expensive in the past, and now it's cheaper and more accessible for all the ophthalmology community. So it's easier now to do it. It's 0.1.
I think. Go ahead.
Sometimes it is still very difficult to obtain the substance because of the cost and availability, especially if you work in a private practice setting. And so I learned from colleagues around the world that heparin can be used. I have tried, but just in one patient, so it doesn't create theory. So, but it would be great, to find substances easily available. That's the whole thing.
Exactly. And if you, as Praveen said, if you don't inject, for example, filter air and only inject the TPA and the anti-VEGF, for example, you can use more dose. You can put 0.4 of TPA and 0.3 of gas. So it depends if you're doing filter air or no. But filter air is very useful because help to mobilize the clot under the retina to the periphery.
That's really good. Anyone wants to give more any comments? Because we are very close to the end. We are now with more than 2 hours and 10 minutes in this very fine panel, and we have more than 100,000 people attending this meeting. That's great. And Marcelo, your case was beautiful, and I love it. And thank you very much to share with us this beautiful moment of your surgery. And I'd like to first thank a lot everyone here, but in special Arturo Alessandrino, that is the president of the Retina Pan America, and he organized everything. And I thank you very much to helping us with this beautiful section. And your words, man, please go ahead and say what you want about the Retina Pan America that has a beautiful, beautiful session that you put together here.
No, Jorge, thank you so much For the Pan American Society, it's really a great honor to be here. I would like to thank you and to thank Tarek for the opportunity to share with all of us our experience. And probably we'll see you again in February in the Retina World Congress, and then in March in our Congress in Buenos Aires. As you know, we have to cancel our Congress of last March, and we are planning to do it again in the next March in Buenos Aires. Thank you so much.
That's really true. It's good to be here and stay with you, stay with a lot of people around the world. We have almost 50 countries connect us, but it's really important to see each other, shake hands, give big hugs. And this is the point for next year, everybody get together at the RWC in Florida. It would be great. I think Tarek has very good words about that. Tarek, please, your final comments.
Well, I just want to really thank you and thank the panelists, and certainly thank all the presenters today for just wonderful cases, and to thank Arturo and the Pan American Society for really participating in what I think is so far the biggest RWC eLive that has gone to date. It may be the largest webinar done in any field at this point. And really, it's a credit to the participation of societies and members from around the world. And I think that in these real difficult times where we can't see each other and can't socialize and talk about cases and learn together, that we can have a different way of learning together. And I look forward to all of you participating again in future events, either online like we're doing now, and certainly hopefully in the future more in person, when we're going to get to do a lot of great things and fun things together live. So again, George, thank you so much for all you've done to moderate and put this together.
Thank you, Tarek. You lead us, you lead RWC, and you are doing a very good job. And thank you very much for all you've done. You are the great one that's put together all this. But I have to thank too Debbie Spence, our vice executive, that she works beautifully. All the good job she has done. And I really say thanks to Debbie and Tiago too. That's your technical team. That's the backstage and help us. And thank all the Retina colleagues around the world, across the world, that's connect to us. Was the biggest meeting that we had so far. That's more than 1,000 and almost 50 countries together. And I have to invite you to still connect with us the next edition. That's going to be very, very good. That's going to be on May with Maria Berrocal, that's here with us, our friend Nati from India, that's a super retina specialist, and our friend Miguel from Uruguay, going to connect the East and the West in one moment. And I have to invite everyone together to be together. And thank you very much, everyone here, to be together. You made this session perfect. And thank you. I hope we need to see each other and celebrate this in a very, very short future. Thank you very much. Have a very good Sunday, everybody. Thank you.
Thank you.
Always a pleasure, Jorge.
Thank you, George. Love you, friends. Take care.
Thank you.
Thank you very much. Thank you. Hope to see you. Hope to see you soon. Hope to see you soon.
Bye. Thank you.
Thank you. Thank you. Have a nice day.
For the third edition of the Retina World Congress. Together, we continue to transform the Retina World community. In the beginning, we had a world-changing vision to unite international retina societies, with each of our last 2 editions drawing 1,000 attendees from almost 70 countries. This vision has now become reality. We bring retina specialists together. Our conference features presentations from global thought leaders, accredited professional education courses, expert panel discussions, and industry exhibits. New in 2019 is RWC Unplugged, a physician-organized and driven session that offers a unique opportunity to learn, share, and discuss controversial topics in retina with a large group of industry experts and clinical leaders. No scripts, no holds barred. Join us for the 3rd edition of the Retina World Congress. Together, we continue to transform the retina world community. In the beginning, we had a world-changing vision to unite international retina societies. With each of our last 2 editions drawing 1,000 attendees from almost 70 countries, this vision